Okay, so after you get your the basic V-team, your vitals, your two types of blood pressure, okay, so the palpated and the auscultated, and then you ask the patient the questions about tobacco use, alcohol use, medication, and allergies, you're going to roll right into the actual cardiac exam, okay? So first thing with every exam is always going to be inspection, okay? So have the patient take off their shirt. So the first part of the inspection process is going to be, you're going to be inspecting the precordium, okay? And that's just the chest area. So you're also looking for basically like heaves, you're looking for thrills, and you're looking for, what's the other one? Like pulsations, anything abnormal in the precordium area. And then the other thing you're looking for is you're looking at the nail beds, okay? So you can do a quick capillary refill test as well. Just pushing, and then you're looking for the nail bed to actually become flush again with blood. So it's a good test for peripheral perfusion. So the next step, obviously after inspection, would usually be, well, it is palpation, but percussion doesn't play a part in this one. Like the respiratory PCL, we had percussion as part of it. There's only 3 parts to the cardiac PCL: inspection, palpation, and then lastly auscultation, okay? So we're going to roll right into palpation. So there's 5 key areas where you need to palpate. The first one is going to be up here. Remember, the heart is kind of shaped like an upside-down triangle, right? So the base of the heart is going to be up here. So you start up here, and you're just feeling for any thrills, any heaves, anything that could be abnormal in that area. Next, you're going to check the apex. So you mind just go ahead and lifting yourself up there. So you're going to go in about the 5th intercostal space. Sorry, my hands are cold.
That's fine.
5th intercostal space, kind of mid-clavicular, and you're looking for, again, heaves, thrills, any of the abnormalities listed in, obviously, the Mosby's. Okay? And next you're going to do, they divide up the next area between the right sternal border and the left sternal border. So it doesn't matter what area or what order you go in as long as you hit each of them. So you're just going to go ahead and palpate, and you're looking, like, again, looking for any pulsations, heaves, thrills. Okay? And then lastly, it's either going to be the axillary or the epigastric area, okay? So you can go ahead and just palpate, okay? And then on the side. So you're basically covering all areas around the precordium for palpation. The next step is going to be you're checking for the PMI, which stands for the position of maximal impulse, okay? And that's going to, or the point of maximal impulse, and that's going to be mid-clavicular line, 5th intercostal space. So it's going to be right around this area here, and if you can't actually feel it, lighten up your touch a little bit. It's not going to be, you don't have to like stress real hard. The other thing you can do too, I'm going to check your carotid at the same time, because the same time you feel the carotid pulsing, you should feel the PMI. Okay. So once you get the PMI should be about 1 centimeter in size, and anything bigger than that, or if it's in multiple spaces, it should be. It's something that you might start thinking maybe left ventricular hypertrophy, because it's bigger than normal. You know what I'm saying? So after you're done with palpation, you're going to move right into auscultation, okay? So auscultation is, again, there's 5 main areas where you want to auscultate, and I'll just run through it real quick before we go on. So the right 2nd intercostal space, mid-clavicular line. So, and if you wanted to, if you remember from the respiratory PCL, easy way to find this is go ahead and find the sternal notch, come down to where the angle of Louis is. So it's right in this area here, and then just shoot over, and this will be your first listening spot, first auscultating spot. And this is going to be your aortic auscultation spot. From there, directly over 2nd intercostal space on the left side is going to be your pulmonary, your first pulmonary spot. Then the 3rd intercostal space down here is going to be your secondary pulmonic valve spot, listening spot. From there down, and you can kind of come in an exaggerated C shape. So down in this area here is going to be the tricuspid valve, and then just below that, where that apex is going to be the last spot, the mitral valve, listening spot. So 5 total. Real good way to remember this is if you take your right hand and you kind of go like this. 2 second intercostal spaces, 3, 4, and 5. So it's kind of like you're grabbing at the patient, and that's those 5 spots. Now you don't want to take your stethoscope, and you don't want to pick it up every time to try and find the spots. You're going to lose it, okay? So once you find a good sound, what you want to do is just gently move the stethoscope head down that semi-C shape. You get what I'm saying? So go ahead and real quick listen. You can just breathe normally for me. Okay. Do you mind just kind of adjusting yourself there a little bit? Okay. And you'll also notice, too, that 5th intercostal spot, you're going to get probably the best sound from the heart. It's the easiest one to auscultate because it's the mitral valve. It's that left ventricular contraction going through the mitral valve. So that's always the easiest one for everyone to listen to. So other than that, up top here is pretty easy as well because it's close to the sternum. So now the other thing with the auscultation aspect of this is 5 different locations, 3 different positions for the patient. Sitting, obviously, and then have the patient lay down, same 5 spots, and then lastly in the left lateral recumbent. So the patient's on their left side, and the easiest way to do this is if you come up behind them, and then you can go, and it's a lot easier to work this way instead of trying to work in front of them, and like, it's more difficult that way. So it's easier to come up behind the patient and then listen that way. So you can go ahead and sit up. All right. So that pretty much covers auscultation of the cardiac portion of everything. So that's the heart. And what you're listening for is things like rubs. You're listening for murmurs, which is that regurg sound from the valves. You're also listening for, things like heaves in different areas, but you can also feel those. So go ahead and review the Mosbys for the pertinent positives when it comes to listening. Okay. So the next section. Now I don't have a bell on here, but the next couple sections they require a bell. It's not a big deal if you don't, but a diaphragm will work. But the next section is all about blood vessels, okay? So the first thing we're going to do is we're going to palpate the major vessels that you can palpate. So first thing we're going to do is palpate the carotid pulse, just like I did before. So all you have to do is find the trachea, and again, you can do that going back to our respiratory PCL. Cardiac notch, and then just kind of come up, and then just off to the side. And you should just, with light pressure, you should just be able to feel it. Sometimes you have to adjust. Okay, it's pretty faint, but you can feel it usually. Okay, so that's carotid pulse. Next pulse you're going to feel is the brachial pulse. Okay, and anything with a long bone is going to be able to have a palpated pulse, or basically an artery over a bone. Okay.